morning. It's a pleasure to be here, and I'm grateful for the invitation to talk to you about the problem of delirium in older adults. This is an important problem that geriatricians and families and patients deal with all too commonly. And it's very hard to get a picture of delirium and what it's like. And the closest I've been ever able to come to is this little cartoon, which is from Dumbo, the elephant. It's the pink elephants on parade slide, and when Dumbo is drunk in the movie, he has this this wild dream. So that's we're not talking about alcohol-induced delirium, but there are some features and things that are important. So what I would like you all to be able to take away from this is to be able to describe the increased risks and costs that are associated with in-hospital delirium. I'd like you to be able to recognize delirium when it occurs, in a family member. Would like you to be able to identify risk factors for delirium that occur both prior to a person coming to the hospital and then things that can occur inside the hospital that may lead to delirium. And then I want you to be able to think about steps that can be taken to prevent delirium, especially in the hospital, and then thinking about if somebody becomes delirious, how do you actually go ahead and manage that. So that's the order of the talk, and that's what I'm going to be going through today. So what is delirium? So it is an acute confusional state. So somebody will all of a sudden change in their ability to attend and their ability to think. So in contrast to something like a dementing disorder, which may occur gradually over time, delirium is characterized by a sudden change in attention and cognition. In hospital delirium, which is where it's encountered where delirium is encountered most often, it's very, very common. It's actually life-threatening for older people. There's an increased death rate when people become delirious, and it is a potentially preventable problem that can occur. So it's just not good for my patients. It's not good for your family members. If you are an older adult, if you become delirious, it will not be good for you. So delirium leads to increased length of stay in the hospital. It increases the long-term care placement rates. So if you're delirious, then you're more likely to wind up not being able to go home, and you're more likely to wind up in a nursing home setting. And it actually increases the risk of dying in hospital. So how does one actually recognize delirium? How do you make this diagnosis? So there is a screening method called the confusion assessment method. And this assesses 4 mental status features. So the first one is the acute onset of change and a fluctuating course. The second diagnostic criteria is inattention. Somebody's unable to pay attention or follow or track along. The third is disorganized thinking, and the fourth is an altered level of consciousness. And the confusion assessment method is something that can be completed in 5 minutes by a care provider. I think that lay people are certainly capable of looking for these criteria and understanding that a change has occurred. And it's well understood by physicians, nurses, and lay interviewers. This has been a very well validated tool for making a diagnosis of delirium. So the way this works is the first feature is this acute onset of change and fluctuation in the course of mental status. So I'm going to give you an example, and the example is something that happened to my mother-in-law. So my wife hosted a luncheon with her mom several years ago, and after the luncheon, my mother-in-law went and laid down for a nap, and my wife cleaned up in the kitchen. But then when my mother-in-law woke up, She did not know where she was, and she was completely disoriented. And this was a dramatic change from just an hour or so beforehand. She was unable to pay attention to what my wife was saying to her and asking questions. When we on a phone conversation, I asked if my mother-in-law had a fever and could we take a temperature. And my wife asked her mom where the thermometer was, and she said, "Well, you know, it's in a tree outside." So it was pretty dramatic, and she was not able to move from and attend to one particular topic and stay on track. So both of these features, the acute onset and fluctuation in mental status and the inattention, have to be present. Then you have to have one or the other of the other two. So either disorganized thinking, which I believe my mother-in-law had, and an altered level of consciousness. And she was a little groggy, but she was actually able to be aroused. And if 1 and 2 or 3 or 4 are present, then that makes a diagnosis of delirium. And in my mother-in-law's case, what had actually happened was she'd laid down and she had the acute onset of a pneumonia, and she wound up being hospitalized, and her delirium was actually, it occurred outside the hospital, but then it carried forward into the hospitalization and made it much more complicated. So how can you tell if somebody is actually at risk of developing delirium? And from work that's been done by Sharon Inouye, who was at Yale and now at Harvard, you need to think about these particular risk concepts. So somebody may have an underlying susceptibility that can range from a high susceptibility of delirium to a low susceptibility. And then you need to think about the environmental stress or insult, which can be either a large insult, like being in an intensive care unit where there are many things going on, or a low insult where somebody may be on a hospital ward or in a recovering in a rehabilitation unit. And theoretically, you could take somebody with a low predisposition to delirium and put them in an environment which is actually quite stressful, where there are a lot of problems or challenges going on to their cognition, and they might become delirious. Or you can take somebody who has a high underlying susceptibility to delirium and put them even in a calm environment where they may still become delirious because of their underlying predilection. So what are the risk factors that people might actually bring to the hospital? So on the right-hand column that says adjusted RR, that's adjusted relative risk. Okay? So if you are visually impaired, you are 3.5 times more likely to become delirious in the hospital. If you have a severe illness, and the criteria here were some rating scales of severe illness, but if somebody has low blood pressure, breathing quickly, high fever, those are the kinds of things that would be characterized as a severe illness. That also raises the risk 3.5-fold. If somebody has underlying cognitive impairment, if they already have a dementia, that increases the risk by 2.8 times. And if they're dehydrated, and that's what's meant by a BUN to creatinine ratio of greater than 18, if they're relatively dehydrated and they haven't had a lot to eat or drink in the past 24 to 48 hours, that also increases the risk. It doubles it. So you can imagine if somebody got sick at home and they weren't taking in a lot of food and nutrition, and before being discovered and coming to medical attention, that in itself will increase the risk of becoming delirious. Once a person is in the hospital, these are the kinds of things that can predispose to delirium. So the use of physical restraints is associated with delirium. That increases the risk 4.4 times. And you can imagine if somebody is confused and they're tied down or immobilized due to medical necessity, they're struggling against this, they don't understand what's going on, and all that does is contribute to the confusion. If people are malnourished, and this is described or identified by low protein levels, low albumin levels in the blood, that